right, so hello and welcome to MSK Research Brief. This is a brief podcast to keep physical therapists and other like-minded MSK clinicians up to date on research literature. And today is the author interview. We did one before with Anya Franz related to the previous article. We've got Kory Zimney here related to the low 2020. He was a principal author for the study, or the contact author for evaluations treatment for low back pain. So it's really exciting to have you on. We reviewed your article in the month of June related to the clinical ritual of low back pain. Really interesting concept. So I'm really excited to have you, Kory. Thank you for joining me.
Yeah, thanks for having me.
Good. So we're just going to quick fire a couple questions here for you, and we'll get it out to our listeners. They've responded to some feedback, and they had some follow-up questions with regards to this research article. So we'll see what you have to say about the paper.
Sounds great.
First one's plain and simple. It's probably always going to be a leading question for us, but if you had to repeat this study today, what would you do differently about it?
Yeah, obviously it's what every researcher, after you get done with the study, you kind of ask yourself those questions and stuff like that. Obviously it was a very pragmatic study, because it's real time in the clinic and stuff. So it wasn't really set up. It was more so exploratory in that nature, just curious to see what we could find. We kind of always individually kind of talked about that. We know the therapeutic alliance is starting to develop in that time frame. We know therapeutic alliance can decrease pain, can improve function when you start gaining that therapeutic alliance and stuff. So it wasn't necessarily meant to be pure cause and effect, because it's not set up to be that way. Future things, there could be a way of potentially using like a control group, so where somebody maybe just was talked to or went through motion that would simulate kind of an evaluation. So was it truly evaluation, or was it just time and talking to somebody? So that's something. In the paper, I think we'd mentioned potentially even reversing the order. If you did the objective first and subjective, because the subjective had bigger, but was that just because you got that initial response? So maybe if you did objective first, again, I know that's not normally how we do treatment, but maybe that shift and change could have been because of that too. So obviously maybe some mixed methods, kind of doing some, qualitative, just asking patients, afterwards, what they thought the changes might have been from and things. So, or maybe even like a way to classify the different subjective things, kind of look at it, videotape it, watch it afterwards and see, they spent more time on their injury. They spent more time talking about other aspects and stuff like that. Could have that had any correlation? So yeah, lots of different avenues, obviously, to explore as we start trying to really unpack this wonderful thing called the clinical encounter and all the rituals that go behind it. So.
Yeah, boy, there was a lot of information that you had right there. So obviously we see the words pragmatic used very often in this type of study. It was an observational study, which then you're relating, the act that this is not a cause and effect study. So obviously there was no control group. So we're only able to determine causation or correlation, or correlation, not causation, with this type of a study. So I appreciate the idea of a control. It would be really interesting to see if there's kind of a placebo type examination or history taking with the patient to check their boxes, but not necessarily go through, some of those therapeutic contents of history taking and physical examination, everything that you were talking about in this study. So really interesting stuff from that standpoint. You mentioned time. I'm glad you mentioned time here, because you had a really interesting treatment effect that was derived out of your study. This leads to my next question. There was a negative correlation, negative 0.578, between the examination duration and the pain catastrophizing scale outcomes afterwards. So do you have any experiences related to any qualitative information from a patient perspective maybe to share, or any information you can glean from that? I thought it was a really interesting statistic that came out of the study.
Yeah, and obviously with only 4 therapists, we'd have to run this on more people to see how strong that was and stuff like that. But yeah, I think sometimes, I think we're, and the reason we pointed that out in the studies, we kind of always, I think sometimes clinicians, we have this, if I had more time, I could connect with them better. If I had more time, I would get a better outcome. And to be honest, I'm not always, I think it could be kind of a U-shaped type of situation, where obviously too little time isn't good, but too much time might be, do we spend too much time over-explaining things? And do we spend, as we over-explain things, does it become information overload? Does it maybe catastrophize the patient a little bit more because they start thinking too many things? And is there kind of a sweet spot? It's like exercise, One rep's not going to do it. 5,000 might be too many. It's finding
Yeah.
the right number of reps in between. So, so I think it could be in line with that potentially. Obviously every patient's unique, so their, kind of tipping point is going to probably be different. But I think it's just something clinically that popped up in this study, and something we wanted to note. Just that I think it's something to think about from a clinical perspective. Is that more time isn't always better. More is more, better is better.
Yeah.
And
Yeah.
that's something we have to learn sometimes, that, we have so much we want to explain, so much we want to get to. We also have to be respectful of what the patient can take on, and that maybe sometimes shorter in some situations may be a little bit better and stuff like that. So again, obviously, we couldn't definitively show anything like that with a study like this, but it was an interesting observation that we thought was worthwhile to consider, and obviously something that we'd have to explore with, having more people controlling for time a little bit differently, have a way of maybe some kind of measurement with the patient if they think they got too much info, too little info, whatever it might be. So those are all things future we could explore in more depth from a research perspective, but we felt it was an interesting finding worthwhile to report. And I think it kind of fits in line with that there may be a little bit of a U-shaped type of curve, that too little is too little, too much is too much, and the old Goldilocks
Yeah.
principle to play, that the just right is just right.
You took the words right out of my mouth. Here, I'll throw this concept at you then. Is there an examination fatigue from either the provider standpoint or from the patient standpoint? And, obviously you can become overwhelmed with information. At what point does the amount of information we're throwing at the patient start to become overwhelming or catastrophizing, in the wrong mindset, or the right circumstances? So, super
Yeah,
interesting.
absolutely.
So we'll move on to my next question here. It relates to pressure threshold testing. So it was completed in 2 remote locations. So obviously the subjects of the study were low back pain. So we're considering, the low back pain, the L3 spinous process was local to the area, but then the remote locations were the trapezius pain pressure threshold testing in the hand. There was reported statistically significant changes in low back pain pressure threshold testing after physical examination. And there appeared to be a relationship between the therapist's perceived rapport, kind of that therapeutic alliance, and a change in the trapezius pain pressure threshold testing. So one of those remote locations. Why didn't we see it at the hand? Do you have any thoughts from a physiological perspective? If we're saying that, okay, it's possible for remote location pain pressure threshold testings to change, then why isn't it a global change? Why just the trapezius, not the hand, vice versa?
Yeah. And again, obviously the limitation within the study, the reason we did that was we're looking at peripheral versus more of a centrally sensitized state, so we wanted to see local to see how those changes would occur. And then the other areas, trapezius in the hand, we're looking to see was maybe potentially a more centrally sensitized state. We didn't do anything to evaluate were they more centrally sensitized or not. We didn't do like a central sensatory inventory on them to see. It could have been how the groups could have been slightly different between each therapist. And so, that finding, why it showed up in one or not the other, there's just, unfortunately, too much noise for me to want to speculate on that one.
Yeah.
In regards to why we saw it in the trap and not the hand. And again, it was a pretty small, difference between them. And so, my early guess is to say it's probably just noise, something that may not be a significant finding. But it would be something, again, going, what we could do in the future is look at people that are more maybe nociceptive type pain compared to a nocioplastic, more centrally sensitized state. Would you see differences then? But we never investigated that with this.
Yeah. No, I appreciate this. That question's, far exceeds the purposes of the study. But I was, just curious as far as your perspective. And have you seen then, just kind of a side note, pain pressure threshold testing at the lower extremity for low back? I haven't personally seen it. Obviously, you're more ear to the ground for this stuff.
Yeah, so the reason we chose the upper trap and hand, one is just ease of access, because you do want to have pressure onto the skin, so they already had their shirts off, so it was easy to do the upper trap. The other thing is kind of just from a normative standpoint, there has been, some normative data in the lower extremity, but the hand and the upper trap are probably 2 of the most common places that it's been studied. So again, we had easier normative quantitative data to kind of peek
Yeah.
at some of that to see if there was any differences. And nothing big showed up with the normative data, but that's partly why we picked those two, just because they're so commonly done.
Okay, excellent. I like it. Yeah, and accessibility is a big player here, yeah, especially when you're looking at pragmatic study. All right, well, great. Thank you so much, Kory. I really appreciate your time and reviewing some of these questions. It's always insightful for me to hear from you related to the study, and hopefully it's helpful for other people.
Right.
If you obviously you're an instructor, if you have any students that would like to stay up to date on more research, MSK Research Brief is a free resource. Check us out at mskresearchbrief.com. We're on Facebook, Instagram, Twitter. There's a LinkedIn profile page. You can follow me that I institute all those posts, Michael post. And again, I appreciate you for your time and your effort.